Let's begin with our topic, and our today's topic of emergency medicine is acute bleeding. First, what hemostasis is. Hemostasis is stasis mean to stop. Hemo is for the blood. So hemostasis is the term used to stop the bleeding or to control bleeding after the acute bleeding occurs. So hemostasis is very important to prevent very serious fatal complications that can be associated with acute bleeding. So hemostasis is stoppage of the bleeding or controlling the blood loss. So what are different mechanisms that play an important role in controlling the blood loss or in controlling the bleeding? We will discuss that in detail. So first, hemostasis. What happens is whenever bleeding occurs, there is injury to the blood vessel. Blood vessels, we have arteries, we have veins. Both together, arteries and veins, they are known as the blood vessels. And whenever there is injury to the blood vessel, there is bleeding. Depending on whether it's slight bleeding, it's moderate bleeding, or massive hemorrhage, the management will be different accordingly, but the first step that leads to the bleeding is the vascular injury or injury to the blood vessel. That's blood vessel with the blood present inside, and these are the blood cells. Then the next step after the rupture or injury to the blood vessel is the vasoconstriction. So first thing that occurs, vasoconstriction, that's the mechanism to control the blood loss, and there is vasoconstriction. Then after the vasoconstriction, there is platelet activation. Platelets are the cells, blood cells, which are responsible for the blood clotting. And the clotting of the blood helps in the stoppage of the blood loss or bleeding. So first step after the injury to the blood vessel is the vasoconstriction, narrowing of the blood vessel, which plays an important role in hemostasis. After the vasoconstriction, then we have platelet activation, which are the cells which are responsible for controlling the blood loss or causing the blood clot formation. And this sometimes we have congenital abnormalities abnormalities that have low platelet counts, thrombocytopenia. These people are predisposed to the hemorrhages or bleeding under the skin because they have low level of platelets, and platelets are the cells which are responsible for the controlling the blood loss by blood clotting. So first vasoconstriction, then we have platelet activation. The collagen in the blood vessel which is present is responsible for this mechanism of hemostasis, especially the vasoconstriction. Vasoconstriction by the help of collagen present in the blood vessel causes vasoconstriction and help in the stoppage of blood loss. Then another step that mainly comes under the heading of secondary hemostasis. First, the primary hemostasis, main step, vasoconstriction and platelet activation as a result of the collagen present in the blood vessel. Then after that, the next step is the coagulation cascade activation, and this is further help in the stoppage of the bleeding. And this is mainly the tissue factor. So we have collagen factor after the rupture or the injury of the blood vessel, collagen factor. We have the vasoconstriction, activation of the platelets. Then we have tissue factor. Tissue factor is responsible for the coagulation cascade. Then antithrombotic control mechanisms. Antithrombotic control mechanism. Antithrombotic are the mechanisms which prevent the blood clotting. And when those factors are active or they are playing role, they prevent the coagulation or clotting of the blood. And if the clotting or coagulation is not effective, then the bleeding won't stop and there is constant blood loss. The platelet activation here require two other factors. One is von Willebrand factor, and then we need the fibrinogen for the platelet activation to perform the function. And this helps in the formation of platelet plaque. Then it forms the blood clot, and this blood clot here, the fibrinogen that is present is converted into the fibrin, and this fibrin are the thread-like network or meshwork, and they, along with the platelets, they help in the formation of the blood clot. And then the coagulation cascade, here we have the thrombin also. Thrombin is another factor that plays an important role in the conversion of fibrinogen to fibrin. And then ultimately we have fibrinolysis and clot degradation. So if I summarize it in it's very nice description of how the hemostasis occurs. So if I summarize it, first there is injury to the blood vessel, so damage to the vascular endothelium. What happens? Two important factors. We have collagen factor, then we have the tissue factor. With the collagen factor, the first thing that occurs is the constriction of the blood vessel. That's the immediate response of the blood vessel, so the blood loss can be control. So vasoconstriction, then the platelet cell activation. Platelets are the cells which are responsible for the blood clotting, but to form a blood clot, these platelets they require the fibrin, which are the fibers that along with the platelets they form the blood clot, and they need at this point two factors, von Willebrand factor and the fibrinogen. This fibrinogen convert to fibrin under the influence of the thrombin. Thrombin comes from the coagulation cascade, and this fibrinogen convert to fibrin along with the platelets from the blood clot. And then this clot, once the bleeding is stopped, then this needs to be degraded. And this is caused by fibrinolytic agents. Lysis is the breakdown. So once the fibrin is broken down, there is degradation of the blood clot. So we have a coagulation cascade. Then we have collagen factor, we have the tissue factor, we have from the coagulation cascade thrombin that converts fibrinogen to fibrin and helps in the formation of blood clot. So here again, plasmin. Plasmin is like thrombin. Thrombin converts fibrinogen to fibrin. We have plasmin. Once the blood clot is formed, it causes fibrinolysis. And as I mentioned, this phase is the primary hemostasis, first step for the control of the blood loss. This is primary hemostasis, and the coagulation cascade, that's the secondary hemostasis. Next, some anatomic essentials associated with acute bleeding. That's the blood with the blood cells. Then there is endothelium, vascular endothelium. Endothelium is the lining of the blood vessel. Injury to that blood vessel or vascular endothelium lead to the bleeding. So first we have the vascular endothelium. Then, as we mentioned in the previous slide also, there is platelets, functional platelets. These are the platelets. There are three types of cells present in the blood. We have red blood cells or erythrocytes. Erythro is red. We have white blood cells and leukocytes. They have separate function. Red blood cells carry oxygen. They have hemoglobin. White blood cells, also known as the leukocytes. Leukocytes are white blood cells, they fight infection. And then we have platelets. Platelets or thrombocytes. The other name for platelets is the thrombocytes. So it's very self-explanatory that the formation of the thrombus or clot, these are the cells that form the blood clot. So these are the functional platelets, that's the another anatomic essential. And then we have plasma coagulation cascade that cause the release of thrombin that convert fibrinogen to fibrin. So these are three very important factors in the blood coagulation or controlling the acute bleeding. Vascular endothelium, then we have platelet activation, and then activation of the coagulation cascade. Again, primary hemostasis, we already talked about this. Primary hemostasis, the vascular endothelium. Endothelium is the lining of the blood vessel. Injury to the lining of the blood vessel cause activation of different steps, and this can cause leads to hemostasis. So endothelium, that's the vascular endothelium. Next, what happens? You see, these are the platelets present in the blood vessel. After the damage to the vascular endothelium, these platelets, which are the cells responsible for the blood clotting, then we have, these are the fibrinogens. So these are fibrinogens. These are the platelets. On the platelets, we have the glycoprotein 2B and 3A receptor. Receptor are responsible for different substances can attach to them and perform the function. So platelets, they have receptors on the surface known as glycoprotein 2B and 3A receptor, and then we have, these are the fibrinogens attached to the receptors, and this form a platelet cause the, we can say platelet plug is fibrinogen converted to fibrin. Along with the platelet, they form a platelet plug or the clot. And then we have the exposed von Willebrand factor. So, as we mentioned before, as I talked about this, that the platelet activation requires two important factors. One is fibrinogen, then we have von Willebrand factor. This is the von Willebrand factor, and then we have on the surface glycoprotein 2B and 3A receptor. along with the fibrinogen and the von Willebrand factor, it leads to the formation of platelet plug or the clot, blood clot. This is the extracellular matrix. So at the extracellular matrix, we have the von Willebrand factor. So at one end, we have the endothelium. Damage to that endothelium brings changes in the platelets. They become activated. They form the platelet plug along with fibrinogen and von Willebrand factor. Next, secondary hemostasis, which mainly involves the coagulation cascade. So in this secondary hemostasis, we have two pathways. One is extrinsic, and then we have the intrinsic pathway. Extrinsic outside, intrinsic inside. Both these pathways bring different changes that leads to secondary hemostasis. And in this, what happens in the extrinsic pathway, we have factor 10. This is converted to factor 10A. Then we have prothrombin, which is converted to thrombin, and thrombin is responsible for the conversion of fibrinogen to fibrin. Then fibrinogen converted to fibrin as a result of thrombin, and this fibrin, it forms the fibers, cross-linked fibers, which attach to the platelets and responsible for the formation of platelet plug or this meshwork that helps in stopping the bleeding. So very important, very simple. We have primary hemostasis, we have secondary hemostasis. Primary hemostasis is mainly vasoconstriction, platelet activation with the help of fibrinogen von Willebrand factor. Then secondary hemostasis is the coagulation cascade. This coagulation cascade, we have intrinsic pathway, we have extrinsic pathway. Factor 10 is converted to 10A, prothrombin to thrombin, fibrinogen to fibrin, and this forms the cross-linked fiber. Also, another secondary hemostasis, now what's going on is we have the von Willebrand factor, we have the fibrinogen, platelet cells, and this all together form the blood clot. So fibrin, these are the fibrin, coagulation cascade, von Willebrand factors. So this is again just the repetition. We have platelets, we have fibrin, then we have von Willebrand factors. All these together forms the platelet plug or the blood clot. Then next we will talk about some red flags. Red flags, as we know, are the indications or the warning signs to alert us that this is the time we should be cautious, or what is the point when we stop. So red flag, history and concerning diagnosis. Warfarin, other anti-thrombotic use. That's a very, very big red flag. Person who is using the drug like warfarin or any other anti-thrombotic drugs, these are the drugs that prevent the blood from the clotting, and these patients or these individuals are prone to the excessive bleeding or acute bleeding. So history of warfarin or anti-thrombotic use. Then the congenital bleeding disorders like hemophilia. If patient has a history of congenital bleeding like hemophilia, again these are the people or the patient who are prone to the bleeding disorders. Then another red flag, thrombocytopenia. These are the platelets or platelet dysfunction. So as I mentioned, thrombocytopenia condition where the platelets count is low or less. So if there is thrombocytopenia or platelet dysfunction, if the number of platelet is good enough but they are not functioning properly, their function is effective, then we should, again, it's a red flag, thrombocytopenia. All these are the conditions that leads to internal bleeding. So hemophilia, person on warfarin or antithrombotic use, and thrombocytopenia or platelet dysfunction. Next, another disordered hemostasis. If the hemostasis or the ability to control the blood loss is disorders, again that's a red flag. And now we know, we talked in detail about primary hemostasis, we talked about secondary hemostasis. Any abnormality at any step of those hemostasis steps can cause disordered hemostasis, like altered mental status, confusion, intracranial hemorrhage, and thrombotic thrombocytopenic purpura if low platelet count. So patient who have altered mental status, they maybe have intracranial hemorrhage or they have low platelet count. Next, head trauma or injury also, again, like intracranial hemorrhage can occur. Then we have melena or bloody stools when there is loss of blood in the stool in conditions like acute gastrointestinal hemorrhage. So all these conditions, whenever there is melena can be visible to the naked eye, or sometimes there is loss of blood in the stool, and which is occult blood loss. Different tests needs to be performed to find out if there is internal bleeding or not. If there is head injury, trauma, there is intracranial bleeding, and if there is intracranial hemorrhage or bleeding, patient will present with altered mental status. The fatigue, again, important indication or red flag that needs to be investigated. Patients with internal bleeding, internal hemorrhages, usually they will be presenting with fatigue because of low iron, low hemoglobin level. They are very tired, weak, restless. They just lie or get up and then lie down on another spot because they have no energy, lack of energy, and there is fatigue. Dyspnea, shortness of breath, is again very, very common as a result of acute bleeding. And the reason is simple: because of poor supply of oxygen to the body and decreased supply of oxygen, there is shortness of breath, and there is air hunger to compensate for that decreased oxygen level. Chest pain is also present. Then we have sometimes there is syncope is also associated with the acute bleeding. And as I mentioned, all these features are the result of anemia that occurs as a result of the acute bleeding. So anemia can have shortness of breath, fatigue, chest pain, and syncope. Another low platelet level, thrombocytopenia. It can idiopathic thrombocytopenia or medication associated thrombocytopenia. So any decreased level of platelets or low platelet count is the warning sign that this patient will lead to acute bleeding. Recent heparin used. Recent heparin used can cause heparin-induced thrombocytopenia. So heparin use can cause thrombocytopenia. Sepsis, trauma, or malignancy. Again, it can be associated with the hemolysis, elevated liver, low platelet count syndrome. So all that is sepsis, trauma, or malignancy. Then recent afebrile bloody diarrhea. So bloody diarrhea is also can be due to hemolytic uremic syndrome. So recent afebrile, without any fever, there is bloody stool or blood in the stool. That is because of hemolytic uremic syndrome. Uremia is increased level of uric acid that is toxic. This is because of the involvement of hemolytic uremic syndrome and it can cause bloody diarrhea. So again, history of thrombocytopenia, and this thrombocytopenia can be result of use of heparin which cause heparin-induced thrombocytopenia. Then HELP syndrome is another important syndrome, and hemolytic uremic syndrome. And how what's the main symptoms that gives us the idea that it might be hemolytic uremic syndrome is afebrile bloody diarrhea. Next, we have bleeding red flags. So, bleeding red flags, what are the examination finding and concerning diagnosis? Let's go over them. First, examination finding, if there is petechiae or purpura. If there is on the skin, we see the petechiae patches, red patches, or the purpura. The diagnosis is thrombocytopenia. So purpura and petechiae is due to thrombocytopenia, which causes the blood bleeding below the skin. Then if there is ecchymosis present, that's due to in which we have elevated INR or elevated partial thromboplastin time. So ecchymosis, elevated INR and elevated partial thromboplastin time. Low platelets and renal failure, if it's present, then we should suspect thrombocytopenic purpura, or as we mentioned, hemolytic uremic syndrome. Whenever there is uremia, it means there is involvement of the kidneys, because the uric acid is cleared by the kidneys, and when there is increased level of uric acid or there is uremia, it might be hemolytic uremic syndrome. And another important symptom we talked about is afebrile bloody stools. Low platelets and thrombosis, if it is present, again is because of heparin-induced thrombocytopenia. So these are some examination findings and what are the concerned diagnoses. All these are because of the low level of platelets. The cause might be different, maybe due to heparin use, maybe due to thrombotic thrombocytopenic purpura, or it may be hemolytic uremic syndrome. But the diagnosis is different. So different findings, the concerning diagnosis, if you see, all these have the problem with the platelet count, because platelets are the cells which are responsible for the blood clotting or stopping the bleeding. Another red flag is disordered hemostasis, intra or retroperitoneal hemorrhage. If there is disordered hemostasis, intraperitoneal or retroperitoneal. Peritoneum is the covering that covers the abdominal organs. Most of the abdominal organs, they are intraperitoneal, except the kidneys. Kidneys are retroperitoneal. They are on the back behind the peritoneum, outside the peritoneum. So there might be intraperitoneal or retroperitoneal blood loss or hemorrhage. Then microangiopathic hemolytic anemia. Microangiopathic, small blood vessels are involved and there is hemolytic anemia as a result of hemolysis of the blood or breakdown of the blood, and this is usually due to thrombotic thrombocytopenic purpura or hemolytic uremic syndrome. Then elevated INR, a partial thromboplastin time, decreased fibrinogen, all these are in the disseminated intravascular coagulation. If there is DIC or disseminated intravascular coagulation, there is elevated INR and decreased fibrinogen level. History, what questions we need to ask, important questions. From where are you bleeding? So if there is a bleeding, then the important question, from where you are bleeding. When did the bleeding begin or start? How much have you bled? Ever bled like this before? Underlying medical problems. So these are very important questions to reach to the, we can say, the provisional diagnosis, not the final diagnosis, but the provisional diagnosis. The most important question, have you any underlying medical condition? Have you had this bleeding like this before? And this is important because that person might have some congenital bleeding disorders like hemophilia, and they have this problem off and on. They might be using some anti-thrombotic medications. They might be on warfarin or heparin. So important questions to ask, these very important to reach the provisional diagnosis. Again, what medications are you taking? So as I mentioned, important question, heparin, warfarin, they are the anti-thrombotic drugs. People who are taking these medications, they are prone to bleeding. So what medications are you taking? Experienced any recent trauma or injury, because head trauma or even any trauma, abdominal trauma, thoracic trauma, all these can lead to some internal hemorrhages or bleeding. So it's important to ask about any recent trauma. Any blood transfusions before? Again, this is important question that gives the indication that patient might have problems, bleeding problems, and that is so bad that they might need the blood transfusions. Any abnormal bleeding before? Next, antithrombotic medications. What are antithrombotic medications? That prevents the blood thrombosis, that prevents the blood clotting and cause the acute bleeding. So some antithrombotic, we have anticoagulant drugs. These are anticoagulants. We have vitamin K antagonist and heparins. Heparin are anticoagulant. And as we talked about, it can cause heparin-induced thrombocytopenia that cause bleeding. So some anticoagulant, vitamin K antagonist. Vitamin K is very important in the controlling the bleeding. So when antagonists are used that are against the vitamin K, leads to decreased level of vitamin K and there is bleeding. Similarly, heparin. And the next anticoagulants are the pentasaccharides, and then we have some direct thrombin inhibitors also. These are the anticoagulants and they prevent the blood clotting. Next, we have some agents that directly affect the platelet levels, either by decreasing the platelet count or by causing platelet dysfunction, and that cause the acute bleeding. These are drugs like non-steroid anti-inflammatory drugs, commonly used drugs, NSAIDs, and these cause platelet level, low platelet count, and cause bleeding below the skin. And then we have also thionopyridines. Next is pyrimidopyrimidine. These are all the antiplatelet agents. And third group is the fibrinolytics, which cause the breakdown of the fibrin. And now we know that fibrin plays an important role in creating that meshwork or the platelet plug. If that fibrin is not present or there is fibrinolysis, then it can cause the acute bleeding. So these are the plasminogen activators. Next, some associated symptoms. In the associated symptoms, the systemic symptoms, there is fever, fatigue, dyspnea, shortness of breath, chest pain, dizziness. So all these are associated symptoms, and all these are due to associated anemia. Mental status, effect on the mental status is due to intracranial hemorrhage that occurs and then maybe due to trauma or maybe due to some internal bleeding as a result of disordered or decreased platelet count. Changes in the mental status. What are the changes or symptoms in the skin? We already talked about them. There is purpura, petechiae, rash, ecchymosis, and are present. Next, past medical history, liver diseases, important. We need to ask about the liver diseases, any renal diseases, and any past medications. All these are important to ask. On physical examinations, what are the findings? We have general appearance of the patient and then the vital signs of the patient with the acute bleeding. General appearance, there is anxiety and restlessness. Skin color is changed, there is pallor, maybe there is cyanosis because of decreased supply of oxygen. All these are important findings. Now, vital signs may be as a result of there is intraperitoneal hemorrhage that affects the vital signs, cause decreased blood pressure, shock. There is tachycardia, a fast heartbeat, and there is hypotension. All these are the changes in the vital signs. And then determination of hemodynamic stability is important. Next, changes in the skin is purpura, petechiae, and ecchymosis. What are the findings in the abdomen? Abdominal tenderness, especially if there is intra-abdominal bleeding, internal bleeding due to trauma, due to rupture, due to injury, or maybe just due to decreased platelet levels, there is tenderness. Abdominal tenderness is present. Occult blood. Occult blood is the blood that is lost with and is not visible to the naked eye. The test is done known as the occult blood test with by putting the specimen of the feces or stool on the slide, and then occult blood developer is placed on the other side. If there is change in the color, it's positive for the blood in the stool. So there might be an occult blood present. Then the changes in the mucous membrane assess for the presence of petechiae in the mucous membrane. Neurologic findings on the examination, assessment of mental status, especially if there is intracranial hemorrhage after the trauma or due to internal bleeding as a result of due to some medications or any injury, there is important to assess the mental status. Then motor and cerebellar function, central nervous system hemorrhage. Special signs or techniques, and in this special sign and technique, one very important test is slide test for blanching skin lesions. This is the test in which the glass slide is pressed against the skin to bring and this causes change in the skin color, and then the refill after the slide is removed. So that's an important test to find out the refill of the blood vessels. Differential diagnosis, primary hemostasis. Differential diagnosis, we have idiopathic thrombocytopenic purpura. Idiopathic means no cause known. So there is idiopathic thrombocytopenic purpura. You can see that's the rash that is present in ITP. Platelet count exclude other causes like lymphoma. So platelet count is important. DIT, drug-induced thrombocytopenia, and again platelet count exclude non-drug causes of thrombocytopenia. And then we have heparin-induced thrombocytopenia. Platelet count, if it's less than, more than 50% decline from pre-heparin baseline, that's an important. HELP syndrome, platelet count, peripheral smear, and LFTs. All these are differential diagnoses, and we talked about them before also. Drugs can cause thrombocytopenia. Then we have idiopathic thrombocytopenic purpura after the use of heparin. If there is fall in the platelet levels, that's also important. Next, TTP and hemolytic uremic syndrome, how we can find these platelet count, and by the peripheral smear, we can find out the thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. Another differential diagnosis is disseminated intravascular coagulation. And this disseminated intravascular coagulation is diagnosed by platelet count, coagulation profile, and also DIC panel. Von Willebrand's disease, again, it's important in the differential diagnosis. Bleeding time is done for the diagnosis. Then medication associated. If patient is taken medications, then that also comes in the differential diagnosis. Varies depending on anti-thrombotic medication. It varies depending on which medicines are used, whether warfarin, heparin, that is which is causing the thrombocytopenia. Now, what are some diagnostic tests that can be performed for the finding of the cause? Complete blood count is very, very important. That gives the platelet count and whether there is thrombocytopenia or not. Peripheral smear is again important. Plasma coagulation profile and a single coagulation factor assays. All these are different lab tests that needs to be performed in patients with the acute bleeding, especially with the history of off and on bleeding. Then what are some general treatment principles? The treatment is idiopathic thrombocytopenic purpura is steroids, IV immunoglobulins, and splenectomy. Idiopathic thrombocytopenic purpura, steroids are effective. Immunoglobulins are very effective in treating thrombocytopenia, and then removal of the spleen, splenectomy. Then heparin-induced thrombocytopenia, very important step, stop heparin. If somebody is on heparin, stop heparin. Again, depending on the level or the number of platelet counts, we need to decide whether it should be stopped abruptly or in stepwise, or anticoagulant. Next, discontinue offending medication. That's an important step in the management. Replenishing deficient hemostatic component if there is disseminated intravascular coagulation. Whatever substance is deficient, we need to replenish that. Von Willebrand's disease, desmopressin and factor replacement. Next, for HELP syndrome, delivery. It's common in pregnancy, occur in pregnancy. Hemolysis, there is elevated liver and enzymes and low platelet count. If that is present, then we should perform the delivery. And after the delivery, the condition is resolved. Hemolytic uremic syndrome treatment is supportive treatment. Thrombotic thrombocytopenic purpura emergent plasma exchange. And for medication associated depends on the agent that is used. Next, general treatment principles for the secondary hemostasis disorders, congenital, hemophilia A and hemophilia B. Usually they are treated by the factor replacement. If it's acquired, then we should, medication associated depends on the agent used and what medicine is used. So congenital hemophilia A and B, acquired mainly associated with the medications, and the management will be according to the drugs used. Next, primary hemostasis, platelet transfusion is important. And secondary hemostasis, fresh frozen plasma, cryoprecipitate. Massive transfusion, transfusion of 10 or more units of red blood cells in less than 24 hours. So again, management, we know that primary hemostasis is due mainly by the platelet plug formation. So primary hemostasis is treated by the transfusion of the platelets. Then secondary hemostasis is by the fresh frozen plasma, because this is mainly by the coagulation cascade. So plasma transfusion will give the deficient factors which are missing, and then also cryoprecipitate, and blood transfusion is also required in massive hemorrhages. Some reversal agents are the antiplatelet agents, RF7A, recombinant fibrinogen 7A, desmopressin platelets, the protamine or RF7A, protamine, possibly RF7A. These are some reversible agents. They can be reversed. We have antiplatelet agents which are responsible for affecting the level of platelets, and we have anticoagulant agents, and these are the reversible type of agents. Then vitamin K, fresh frozen plasma, and PCC. Cryoprecipitate, also a reversal agent, fresh frozen plasma, and amino caproic acid and RF7A. Warfarin over anticoagulation. INR, if it's 3 to 5, omit one warfarin dose. So INR test is an important test in patients who are taking the warfarin, who are using the warfarin, and if the different INR levels an international normalized ratio. So INR level, if it's 3 to 5, then we should omit one warfarin dose. Vitamin K FFP, and PCC. If INR level is between 5 to 9, then we should omit 1 to 2 doses and we should give vitamin K, fresh frozen plasma, PCC, and RF7A. INR now more than 9. What's the management? We should hold the warfarin and we should not give the warfarin. Some special patients and the treatment in the old age, check platelet count and plasma coagulation profile. Exercise heightened caution. In pediatric or children, idiopathic thrombocytopenic purpura and hemolytic uremic syndrome are more likely present, and there is chances of E. coli H70157 infection. So E. coli infection mainly cause hemolytic uremic syndrome, and that's the common cause of acute bleeding in the pediatric age group. Then disposition of the patient, primary goals in the management, hemodynamic stabilization, bleeding control. Any patient with acute bleeding, if it's mild, moderate, or severe, the primary goal is the stabilization, hemodynamic stabilization, or to control the blood loss. That's the most important goal of the therapy. Disorders of hemostasis, workup, and initiation of specific therapy. If there is problem in controlling the blood loss, then we should go for the specific management and the therapy. Discharge from the emergency department and then follow-up is important, especially in patients who have a history of bleeding. Follow-up is very important. In conditions when it is due to some injuries or traumas, once the condition is improved, usually maybe we don't need the follow-up other than the one, but in congenital problems, hemophilia, other bleeding disorders, we need to follow up the patient on the regular basis. Pearls, pitfalls, and myths associated ABCs: assess and reassess vital signs. Missing platelet count to be treated as low platelet count. Again, it's not a very right myth. So missing platelet count, if we don't have platelet count, it means that's low. That's not right. Recombinant factor 7A and vitamin K role is also questionable. So that concludes our topic of acute bleeding. Thanks for watching sqadia.com.